Hello, everyone, and welcome to the Future of Surgery discussion with some esteemed colleagues from around the world. This is a part, of course, of the Giant Health European Health Tech Week. We're so lucky to have some amazing guests from around the world to discuss the future of surgery with technology and innovation and disruption and what we can expect over the next 5, 10, 15, or even 20 years. Our guests so you can pause that there. Let's do the next bit, okay? We have a number of guests that are going to be joining us. The first one is Dr. Rafael Grossman, who's a futurist and entrepreneur innovator from Maine in the US of A. He's well known to people around the world around his vision on the future of surgery. We have Dr. Carla Pugh, who works in California, who has again been disruptive in surgical training and education, using technology to assess performance. We have Dr. Marley Schwibben, who's a professor of surgery in Amsterdam, who's done a lot of work on data analytics and the black box in the OR, as well as being very much interested in gamification and app design for use both for patients and also for training. And also we have Professor Stefano Bini, who works at the UCSF, based out in California, who's professor of orthopedics. And he has an amazing conference that he runs every year called DocSF, bringing digital technologies into the world of orthopedic surgery. But also he's been involved in research using technology. He's been using sensors and working with Google as a partnership to figure out what we can do with rehabilitation and support for those patients undergoing orthopedic surgery. So, a lot to discuss. Some amazing minds for the next hour that will be sharing their expertise. So let's invite the very first guest. It's a great pleasure for me to introduce our first guest in this Future of Surgery session at the Giant Health event at the European Health Tech Week. The next guest is Dr. Rafael Grossman, who most of you will know already from his groundbreaking work in surgery for a number of decades. He's been at the forefront of change, an innovator, a true innovator, who's inspired many people around the world around his vision for surgery and also the way he's helped democratize our practice around the world. He has a passion for innovation. He's also at the forefront of actually using technology to improve healthcare outcomes. He's a thought leader. He's a keynote speaker, a much sought after speaker around the world at many international events. He is a TEDx talker. By that, I mean he's given 5 TEDx talks. Most people struggle to just do one around the world, but obviously people really enjoy hearing his story, his vision, and his work. He was the first person to actually use the Google Glass in surgery back in 2014, I think, inspiring me also personally to delve into the world of innovation. So for the next 15 minutes, I have the joy and pleasure of really asking him questions around the future of surgery, his thoughts, his experiences, and also perhaps thinking about how we're going to change surgery for the better. So without further ado, Rafael, who's currently in Maine in the US, welcome. And thank you for coming to join us at the Giant Health event 2022 at the European Health Tech Week.
Thank you, my friend. It's a pleasure to be here with you. Really honored to share the stage with you, the virtual stage. And thank you for your very kind words. It's it's always an honor to be on your side. And you're before anything my friend and esteemed colleague. So thank you for inviting me.
A real pleasure to have you. And I'm sure the audience will really enjoy what you have to say. I'm excited. So let's first things first. We've had this concept and term that's been called digital health. No one knows where it came from. It's evolved over the last 10 years. And it talks about this convergence of technologies to improve medicine or change the way we practice. Over the last few years, there's this new concept of digital surgery that's really becoming prominent. We're seeing the examples of many technologies now being used to improve surgical performance and outcomes. So I'd like to ask you, what do we mean by this term digital surgery, and where did it come from?
That's a great question. And, as you know, many definitions of digital health are there, and I just try to keep it simple. Maybe because I'm a surgeon, and you know, I want to get things done and not get too much into details that don't matter when the details don't matter. Digital health for me is about using the amazing, close to magical power of technology today to improve how we do healthcare, how we teach, how we learn, how we connect, how we communicate. If we take the last part of the digital health concept and digital health surgery or digital surgery, for me is sort of the equivalent. Is using that power, the technology that we have today in the 21st century, at the dawn of this millennium, to really improve and finally get out of the holes where we've been for the last several decades. You know, if you think about the progress of surgery in the last few decades, it's really been, some people think amazing, but I kind of think we've been in a leash in a way. We had laparoscopic surgery in the early 90s, late the 80s, and then we had the very slow development of robotic assisted surgery. And that's pretty much it, if you think, in the big picture. And I think that we have so much more that we can do with technology today. Thinking about the different options that we have. If we think about spatial computing and how we can use spatial computing to really radically change how we connect and communicate among ourselves, seeking expertise or giving expertise, teaching, educating, learning, but also connecting us humans with the digital realm, right? With the famous electronic medical record, for example, and making things better for us, for the patients, for the outcomes of the patients. I think that that's what I really understand by digital surgery, empowered, augmented surgery by the way of technology.
Yeah, and I think you're absolutely right. I think it is a whole mindset shift, if you like, in some regards. And we're going through these exponential changes quite rapidly. Let's talk about some of the technologies that we're seeing now. A decade ago, we didn't hear about things like spatial computing, AR, VR, and mixed reality and XR, for example. AI and deep machine learning has been coming in, robots, and kind of using visual learning, improving data and analytics, and more robots that have come in. So there's a whole kind of array of technologies. Let's talk about some of them and let me get your views. XR, now you're one of the world's experts on XR. Can you tell us where we are at the moment with XR and where do you think that's heading towards?
Yeah, XR really is that almost the realization of the spatial computing as we think about interacting with the digital world. I'm pretty sure everyone in the audience would know what virtual reality is. We're immersed and isolated in a digitally created environment, and then the AR or a augmented reality lets us superimpose digital to the real world, and then where we can interact in a way, manipulate those digital images as if they were real. Then we are talking about mixed reality, and the whole concept is understood, in simple terms as XR, right? And when we make that applied to medicine, people talk about MXR or medical XR. So I think that we have come so far in the last maybe 5 years or so. If we think about how how we communicated, I always bring, my brick phone, how we communicated just in the 70s, right? And everyone thought that this was crazy. And now, we have the devices that we all have in our pockets, 2 or 3 of them. If we think with the devices that we use to interact with the digital images, and you're very familiar with the Google Glass, right? You and I both, had great experiences with this at the beginning, and for many reasons. So you can see an image floating in there. You can have a digital assistant, but you can see an image, an augmented reality type image, maybe and this quickly went from this to devices that quickly evolved to, something like this HP glasses that really allow immersive virtual reality in a way that, in a portable way that we hadn't seen it before. And then obviously devices like the HoloLens 2, right, that we're very familiar with, or the Magic Leap. This is still the first version of Magic Leap, but these devices are now becoming not just tools that we look at gaming devices or devices that don't really have a meaning in healthcare. Now they're becoming devices that are helping us connect and communicate better among ourselves and with the digital data. And the devices are not just allowing us to see, but the devices are watching us. The devices are analyzing us. They are, tracking your gaze and tracking your attention and maybe tracking your electrical brain activity or tracking your pulse or your respirations. Just using that technology that we don't even see to really augment and enhance the experience to limits that are only created by our limited imagination, really.
Yeah, no, you're absolutely right. I mean, what we've seen during the pandemic, pre-pandemic, these technologies were available, but very much limited because of lack of content and lack of desire almost. Now we've seen a huge change because pandemic has forced us to go more remote. We're doing more virtual learning, the environment's changed, simulations coming in. So we're now seeing a market now that's ripe for disruption for XR technologies. And people now talk about this concept of the metaverse, or what we call it now, the surgiverse, right? So let's talk about the surgiverse. What do you think in the future an interaction will look like in this new world of thinking around the metaverse that's now taking place, but we could call it the surgiverse? What are your thoughts around that, Rafael?
Well, I think that it's a fascinating term, right? The metaverse, the magic verse, many terminologies. You I think, talk first about the metaversity, right? Using that metaverse to educate and to learn. And that's becoming more and more a thing of commonality. We have the companies in the US only, there are more than, I think, 25 college campuses that are completely digitized, completely available in virtual reality in a Pico headset or in a Quest headset. You can visit that virtual world as it was real, but in digital, right? In virtual reality. So in surgery, we go even beyond that. You have platforms like Fundamental VR, for example, Fundamental Surgery, which I'm an advisor for them. There are many other fantastic, you have medical reality, right? You have many other uses of the XR metaverse for learning and for teaching. But then if we think a little bit further, if we imagine how we can use haptics, for example, to enhance, right? This is the old sense glove, right?
What is that in your hand? Describe. Let's play around with it. What is it?
Yeah, so this is the first edition of the sense glove, right? The sense glove allows the user, right? And this is about 3 years old already, and they already came out with a newer version. But this allows the user to feel, and it looks a little clunky. It looks a little bit like Edward Scissorhands almost, right? But when you are in the virtual world and when you can basically be read by the device, and the device is checking your movements, and when you can feel that tissue, for example, you are drilling virtually into a knee, into the bone of the knee, or you are cutting the bone, and you feel the different density of tissue. But when you see it in high definition, it's amazing. But when you can feel that to me brings the experience to a different level. And the people talk about there's more and more data out there validating the use of haptics in virtual reality. And that is clear. And as time goes by, we're going to have more and more data and validation, which is obviously what we need for all of this stuff to really become usable in medicine, right? But when you add haptics, I think that it's a totally different level. I almost, people ask me, and so why is haptics so important? And I'd say, well, imagine someone who's blind and they can only do Braille. And imagine if you took the Braille away and suddenly you give them the haptics of Braille and they can read that image in their brain of what they're reading. Imagine if you are missing a sense and suddenly you are given that sense. Imagine how much exponentially you are elevated and augmented. There is OVR, which is a technology here from the US, where they put a little chip on the headset and you can smell what you see and what you can touch in virtual reality. I've baked a pizza with mushrooms and tomatoes and basil, and you can smell the aromas that you're seeing it's just fantastic, and we're barely touching the surface. So I think that in surgery, we are going to be able to perform before we actually do it in humans. We can bring simulation, step procedural surgery to a level that we had never had before. And then you're very familiar with telestration or teleconsultations, where you can bring an avatar. You have companies that you and I have worked with, Beam, and other companies where you can bring an avatar of the digital person. Oh, how's that better than a 2D image of Shafi and I talking about a case? Well, it is better because you enhance that reality in a way. Instead of talking to a screen, I can have your avatar or your digital self in there with me, talking about a common digital holographic image of a abdominal reconstruction of a CAT scan on a tomography or else. And then we can manipulate that image. You in the UK, me in South America, or in North America, or whatever I am. So that is the power. The power is to allow dreams to become true in a real sense, to help patients and help students to become better at helping patients.
Yeah, you're right. I think what you've alluded to is this whole remote working to the next level. We're now using Microsoft Teams, Zoom, other platforms now to connect and communicate, taking away the kind of the barriers of traveling and distance and geography. It kind of changed the world that we live in. We've democratized that whole aspect. And I think what you're saying now is that as we move into XR, into avatars, into kind of remote kind of way of working, we're seeing telementoring, teleproctoring. Technologies now allow us to, train people remotely. And if we go further forward, with the use of 5G technology now coming in with this higher bandwidth, low latency, we're now seeing remote work coming along where you can actually support people in a global level. And that's really important for XR, which is going to be kind of data heavy in that sense. So we look at the world of robots, and obviously now robots are coming in. We saw the first operation being performed remotely in China in 2019 or something, where a person was operating in, I think it was Eastern China, remotely. And we're seeing more of that. Where do you see the future of that? Is there a future for that? Are we saying that's just too far-fetched? Or is it now reality, Rafael, that you've seen?
Yeah, we always think we're short-sighted for technology, right? Amara's law, where we always tend to overemphasize exponential technologies in the short term, and then underemphasize them in the longer term. I think that's what's happening a little bit with robotics. Robotics have been entrenched in the same sort of silo, for 25, 30 years almost. And now we're seeing different companies, from the UK, CMR, really modular robots that are really democratizing robotic-assisted surgery, not the $2 million device, but device that is much more accessible, much more portable, much more modular. I think that is definitely the surgeon of some types of surgery. It's not every surgery. It's another tool to empower and augment us surgeons. And I think that you mentioned democratization is a key word, because it's not just connecting people, but it's bringing that technology, the hardware, the software, the possibility of teaching and learning at a distance. You've done a lot of work in Palestine, great work in Africa, from the UK. I've read recently, we've done some work with Central America. It's about using that technology, which was very, very expensive, which now is not so much that expensive anymore, and that is going to be even less expensive very soon and much better, to bring that technology to democratize indeed what we do, how we teach, how we learn, and how we do. I think that robotic assisted surgery is also telesurgery, how it was thought of when the Da Vinci was invented, basically out of the military, decades and decades ago. I think that is definitely going to be the future of surgery, because you can see obviously many, maybe ethical barriers or legal barriers or reimbursement barriers, but you see how quickly telemedicine has, for example, broken those barriers, especially with a little push of the pandemic, where now you can do telemedicine, for example, in the US, right? You couldn't do telemedicine, not even within the state, but within the health system within the same state. You couldn't do telemedicine because you were not part of the system. Now it's much more liberalized. The same thing is going to happen with robotic surgery. Now we do have to obviously keep very clear parameters to not make this a a zoo or a wild west out there. But I think that people are thinking right about how to do it and how you can have an expert surgeon guide another surgeon remotely by the way of taking over the robotic device, for example, or telestrating. You have companies like Proximity AR, for example, which has done great stuff, mentoring surgeons at a distance, doing robotic surgery in places which would not have that sort of technology. I think that it's very clear that that is the future.
Great, that's really good. I think we're just coming up to the end of this conversation. We could go talk for hours, and it's just the beginning of this conversation. I love all the gadgets that you have, Rafael. I was half expecting you putting out a rabbit at some stage, like a magician, but you have many gadgets. One of those things. So listen, Rafael, look, thank you very much for spending time with us and explaining your vision of that future, which I think is amazing. I think it'd be great for people to follow you going forward about what you're doing and how you're thinking about the future. What's the best way of people following you going forward, Rafael?
Well, really, I think that obviously my Twitter handle is probably the best way to connect with me. I use Twitter not in a personal way, but professionally to communicate, to get info, mostly to learn, and then to give. The Twitter and LinkedIn are probably the best ways, and from there, Gmail and whatnot. But I think Twitter and LinkedIn are good ways to connect and communicate. And, there's always stuff happening out there. And especially now in Twitter, God knows what's going to happen. But I think that is a good channel to certainly connect and learn and teach. So I'm welcome to connect with all of you there. And thank you again for the invitation, Shafi. A great event, a great a platform to really connect minds and have us learn as we should be doing every day.
Great. Well, thank you so much, Rafael, for taking your time out. And hopefully we'll get to see each other face-to-face fairly soon. So I hope you enjoyed that and exploring the great mind of Rafael Grossman, huge experience in innovation and the future of surgery. Do follow him if you can, to follow his story, his journey, and his ideas about how we improve surgery for not just the US, but around the world. So thanks for joining us.
Thank you, my friend. Have a good one.
Well, it's an absolute delight and pleasure to introduce our next guest on this Future of Surgery session at this year's Giant European Health Tech event. So I've been joined by the delightful Professor Carla Pugh, who is Professor of Surgery at Stanford University and Medical School. So Carla, thanks for joining us.
Oh, thanks for having me. This is an extreme delight. Believe me, it's been way too long.
It has. I'm so glad to touch base with you again. I remember seeing you first time at Exponential Medicine in San Diego. I was blown away by Carla's work and what she's been doing and working for so many years, that I felt that we should at least share her experience and her ideas to our audience at Giant Health. So thank you so much. So Carla, I think it'd be good for our audience to know more about you. Can you just tell us about what you do, what your roles are currently, so that people can understand what drives you at the moment?
Oh my goodness, what drives me is data and technology. I am a professor of surgery at Stanford University, and I am the Thomas Cromwell Professor of Surgery, which means that I don't have to work as hard for grant money, and I've got a good mentor. I'm also the Vice Chair of Innovation, which is exciting, a new role in the department. And I'm also director of the Technology-Enabled Clinical Improvement Center. So all things technology, totally believe in it. And I'll be the first one to step into the Star Trek holodeck if we ever build it.
Wonderful, wonderful. So I'm glad, because obviously I think the future of surgery is going to be defined by data, more personalized approach to surgery. And we've kind of been behind the world of what's called digital medicine or digital health. And now we've got this new concept of digital surgery, which I think you're pioneering. So talk about your role in data analytics, what you're seeing in terms of the future of healthcare, future of surgery, and perhaps we can talk about your views around the robots and the escalation of robots in clinical practice.
So my role, I would say in digital surgery has really been around the use of engineering technologies, sensors, motion tracking, synchronizing that with video data, audio data, wearable technologies. And so any wearable, you name it, I'd be willing to try and add it in. I think that, the concept of the quantified surgeon is what's going to get us to that point where surgeons are wearing this technology, they believe in the data and the utility and the value for themselves. I mean, it really is. Everyone wants to be the best they can be. So the best thing to do is to compare not only with your colleagues, but yourself, right? Beat your best self. So it's kind of like hacking your surgical life. And I think that we have a big following of people who are interested in this. I've been collecting data from healthcare practitioners for 20 years. So we started small. We were putting sensors on mannequin trainers and having family practitioners, OBGYN physicians, surgeons doing physical exams on mannequins and quantifying what they're doing. We want to quantify the masters. It's like everyone's like, oh, this is good for medical students. I'm like, the medical students don't have the metrics. You want the medical student not to be better than the best medical student. You want the medical students to be better or to at least get on that learning curve to competency and mastery after the best physicians. So I'm getting the data from the master clinicians. And so that experience, literally my first data collection was at the Moscone Center in 1998. And so now, again, 4 sensors on mannequins, physical exams, and now we're doing wearable technologies on surgeons in the OR. And the data just keeps coming. The realization of the utility of physician-centered metrics. Physician-centered metrics. Everyone's focused on the patient, and rightly so. That's where the money is. It's the biggest data pool. But that information will be incomplete without what the physician is doing to the patient. Hello? There's a whole data stream that's missing.
For a long while. We've kind of been used to the subjective, data of surgeons and their performance. And it's very inaccurate, isn't it? We've always been assessed in that way for as long as I can remember. To have a system now where we can assess a performance or quality of outcome, go back to it and see where the errors might have been if something goes wrong, for example, those insights can be really valuable, aren't they, going forward, right?
Extremely valuable. And you said the right thing. You said the outcomes. So the other thing we're doing is just completely disrupting the concept of which independent variables are important. So the traditional research says, okay, let's take the surgeon that has 20 years in practice and compare them with the one that has 2 or 3 years in practice. Or compare surgeons with medical students to validate, the metrics and the data. I'm like, okay, great. We've done 15 years of validation. The data's there. Let's move on to the next chapter of data analytics and get all the surgeons, the best surgeons in the country, to do the same thing. And that's where the simulated environment, even if it's animal or cadaver procedures or VR, whatever have you, getting 200-300 surgeons to do the exact same procedure and quantify their approach. We're not stratifying them based on specialty or years in practice. We're stratifying them based on the outcome. Who achieved the goal? That's your first level of stratification. You take 250, most times many of them are achieving the goal, but you're still going to get 50 or 60 that may not. And then what you do is you look at the video data, motion data, wearable data. What is it that those persons who achieve the outcome, what are the commonalities that they are doing compared to those who don't? That's the new research protocol. Years of practice, absolutely. I don't care. There may be some retired surgeons who are still dancing circles around the 50-year-old person who's in their peak. There still may be surgeons who are in their 4th, 5th year of practice who are doing 1 or 2 things better. And that's the other thing. It's how do you define your outcomes? Is it overall outcome, or is it outcome for this critical decision-making point in the operation? So you can segment that operation and look at outcomes according to each major task. So lots of opportunities here from a data analytics standpoint, and we're just starting to scratch the surface.
No, absolutely. They say the data, of course, the new oil. And I think in surgery, it's such a big novelty for us. And I think in the UK, for example, we have the GIRFT. And what we're trying to do is reduce the variability for operations, which is a huge problem that have been fully assessed. And also that reduced variability will hopefully improve the outcomes and standardize treatment procedures, which again, as you and I both know, have been so variable in the past. So the next thing I want to talk about is, okay, data is great. And we've got this world of convergence of different technology, which is so exciting in surgery. And surgery seems to be at the kind of epicenter, or the forefront, if you like, of change at the moment. And this whole new world of robots now. We know the intuitive surgical has been out for a long time, which was actually invented in California about 2 decades ago. Now we're seeing a plethora of robots on the market, smaller, sleeker, more flexible. How do you see the future of that? There was a lot of hype before around robots. Now we're seeing perhaps sense of about what they may actually achieve and how they may help us in the future. What are your thoughts about robots and how we use them? What might happen going forward, Carla?
I think the most exciting thing that has happened is, when you go to the innovation conferences, like where we met Exponential Medicine, and you have, surgeons and engineers, computer scientists, data scientists all together, at a conference or in a room. What I really love is that the narrative has changed just a little bit in the right direction so that we can actually make huge progress. When I first started going to some of these conferences 10 years ago, all the engineers and computer scientists were saying to me, are you fearful that we're going to invent robots that are going to take your job? And I'm like, oh my God, no way. Like, bring it on. Like, the day you invent a robot that can take my job as a surgeon, do you know how much value I will have? I will be doing a different job that is so much cooler than what I'm doing right now. So I think, and so that's always shocking to them. And I think because what I understood was the complexity of what we do, and just waiting for that recognition. And now, fast forward 10, 15 years later, after the major hype and the failure of certain things, not even just robot, but just the data, IBM Watson was supposed to take over the world and do decision support and help physicians make decisions. And then they said they didn't have enough data. No, you had the wrong data. You didn't have you were missing some critical components. And that's the workaround that the physicians are doing in the background that's not captured. You didn't add the physician workflow. Same thing in the operating room, the surgeon's workflow. Oh my goodness. It's all in our head, Shafi. Those of us, we know the things that we never verbalize. There's no language for it. You can't create a robot without all of the steps. The steps are in the surgeon's head. So how do you get it out? So I think the new thing that's happening is respect for complexity. And it's not just in surgery, it's broadly, right? I mean, the Tesla self-driving cars, right? You have the GPS system, but guess what? The little kid who's throwing his ball isn't on the Google Map GPS thing. So how are you accounting for the unexpected? And you have to think about that in your programming and your futuristic dreams. And so respect for complexity has now gotten us in this new space, diversity as well, diversity of thought and diversity of patient anatomy. Wow, that's a thing. The aorta's still in the same place for everybody, but the sizes of those branches and where they take off, you can't. Where's the GPS for human anatomy that has some variation in it?
Yeah,
that's respect for complexity is the new buzzword for me, and I love it. And we're getting there.
Yeah, I love those words. I think respect for complexity is a great way to, of course, to mention that. So I guess next question really is, now that we're going on to this more data-driven world that we live in, surgical navigation, you talked about briefly, robots, decision-making still remains much in the domain of our human psyche. It's about judgment. That's hard to define. For example, if you're doing acute surgery, you find something unexpected, what do you do with it? When do you take a patient to theatre for appendicitis? They're hard variables that data may not help us. That, I think, still requires clinical judgment on some cases. Is that intuition sometimes? What are your thoughts about that, Carla?
Yeah, so The cool thing, yes, 100% I agree. Back to respect for complexity, that judgment, and again, all of the things that are noodling in our head when we're looking at, the tissues. I always talk to my colleagues about the visual haptic loop. Like, we are making judgments moment to moment as that anatomy responds to our motor action. You use your instrument, you dissect something, you cut something, you see how the tissue responds, you adjust your motor action. That's super complex. The cool thing about it, Shafi, is that we're actually able to see some of that in the motion data.
Okay.
We're adding EEG to it as well as some eye tracking, and there's a lot of information there, but just in its most simple form. The full choreography of the motion data, especially if you plot it according to velocity, it gets back to what we already know. Experienced surgeons slow down at the most critical parts of an operation, because that's when you are taking in information, visual, haptic. You slow down. Then once you have what you need, then you speed up. It's this first meet and greet with those tissues, okay? On the inflammation scale, I'm ready to put my stitch in, and like, how are you going to respond? And we've had some slap back from that pancreas that's kind of boggy, right? I mean, and then it's a different pancreas the next day or a different bowel. And all of that's happening in our head. And you can see that with the motion data in terms of those moments. So what we're one of the papers we wrote related to, we coined idle time as a metric. And it turns out that that's an important part of the full choreography, not your path length, not only your path length, your working volume and your velocity, but the pausing moments or the moments where you slow down. It's a beautiful thing when you think about it holistically. Pretty amazing.
Yeah, no, I hadn't about the fact that you can define the motions in engineering characteristics, which is great. I think as things go on, of course, it'll be working man with machine, I guess, as we go forward.
Yes.
I'd love to hear about what you're doing now, your current future. What are you thinking about projects-wise? What are you working on? I'd love to share that with the audience.
Ironically, as we speak next week, my team and I are going to is it next week? Yes, next week. The American Urologic Association meeting, and we're partnering with the urologist and another colleague of mine at University of Rochester who has developed 3D printed models of the prostate anatomy. And so the thought of doing a nerve-sparing robotic prostatectomy, and Intuitive is going to be there. They have their data, which I think people don't remember. They do have the motion and movement data. Their data is actually pretty complex and detailed. So we're actually still going to use our more basic motion tracking sensors with the Intuitive robot arm. And then Ahmed Ghazi and his 3D printed anatomy, eye tracking sensors, motion. We're going sensor crazy to really look at experienced robotic surgeons and what are those decision-making points in that procedure that help them spare the nerve, which again is the outcome. And so he has a way of looking at the prostate once it comes out to see the margins, because you care about cancer, but then also see how close and how much movement you had on those nerves, because that's another outcome that's pretty important for patients who have it. What I think is the most exciting part about this, there's two things. One, there's a whole conversation about who owns the data. And it's kind of interesting. So if you think about a hospital that purchases machinery, smart tools, robots, and then the data goes to that machine, you can argue that the hospital owns it within their contract, and then no question, the industry group who sold you that equipment owns it. Now, privacy and so on and so forth is, the hospital can put in that contract that they want the data identified, and you can't have individual data on our surgeons, but you can have pooled data. Scale back to the other side. If I wear a wearable EEG in the OR, that I purchase, that's my data, Shafi. It's my data. So my wearable, my data, the hospital's technology, the hospital's data. Think about it. That's kind of a basic concept, but I think that we're not really talking about it. We have early adopter surgeons who want the data. They're in it. They're like me, like, yeah, I'm jumping in that Star Trek holodeck, hasn't been tested, but, let's do this. But I think if we're going to go broad in this industry, we have to really think about who owns the data, think about data responsibility, think about why we're collecting the data. It's from a quality perspective. The general public wants us to rank the surgeons. We're so far from that. And what does it mean? Okay, we'll rank you on step 7 of a 47-step operation. What does that mean? But that's the natural, public desire is to rank the surgeons, and then I want the best surgeon. But the real value in this data is for, just as you said, to decrease variability and have every surgeon reach the best that they can be. And you can't do that if it's discoverable and you're suing your surgeon for step 7 of a 27-step operation. We have to, as the physicians in this space, control the narrative, design the narrative, brand it properly so that everyone benefits. If we don't do it, it's going to be a hot mess.
And I think you're right. We have to be in control. We have to co-design, understanding what that data means and what that means to our own particular performance and how we assess that. Then that goes on to things like, monetization of the data. It's going to be insurance-based policies based around that data going forward. So there's a whole can of worms will be opened up by capturing and understanding it better. So I think we come to the end of our discussion, Carla. It's been always great to get your insights into the endless possibilities of the future and what you're doing. And you're doing an amazing job, by the way, on a global level, helping surgeons understand this, the future of surgery better, and being very much instrumental in driving forward this whole data analytics and digital surgery. So thank you very much for joining us.
Always have time for you, Shafi. Thank you so much. You are an inspiration, and I am just happy that we can call each other friends, but also partners in this really important endeavor. So thank you for all that you do. I appreciate it.
Thank you so much.
I love the beginning of this, Dr. Shafi. That was great.
Same old, yeah. What can you do, man? What can you do? You gotta blow your own trumpet sometimes. So how was the conference? Did it go well?
It went well, thank you. In big part, thanks to your intervention. It was we had a great session. After that, I had the chance and the honor of interviewing live Louis Rosenberg, who you probably know from his early work in augmented reality. He kind of invented it. He was built the first AR workflow system for the military here in the US and California, and been in that space for a long time. Absolutely fascinating discussion. So that was perfect. And before that, we had Intel speaking. It was a great session.
Did you have a good attendance?
We had 220 people sign up, which for us is about average. But given that we changed location, moved it to April, I was super pleased. We had so many conflicting events. It turns out it's the only weekend in April and May that you can actually do a conference in, because before that, there's the holidays.
Yes.
Afterwards, Mother's Day. It's like you're stuck. It's like there's a Easter. It was like, so everybody was meeting that weekend. Super hard to get people to show up.
Brilliant, man. Well, thanks for doing it for today. So what we were doing, we couldn't get everyone together. It was just impossible to fit everyone's diaries together. So in the end, we've gone for individual interviews and we put it all together. So I've already interviewed Carla Pugh, that you'll know from Stanford, and also Rafael. And Marley's would join us today. So Puria.
Yes. So
Marley's will join us soon. She phoned me just a few minutes ago. She just finished long case, theatre. So she will join us in due course. What I suggest you do with her is I'll start with Stefano, get it out of the way, and then we can then Yeah, then or we could. The other thing I think we could do it together. So if she joins, we could do it together as a twosome of three, a little panel, or we could do it separately. What do you suggest, Priya?
I think if she joins, it will make it more dynamic. So of course it would be better, but well, it depends when she can join us and how.
She said within. So
You've never seen Shafi in my talk. You got lots of dynamic here, brother. We don't need it. We don't need others. We got the dynamic. We got it. We got the dynamism.
Okay, let's do our one now then,
Mhm.
and then we can do Marley's next. Okay.
Yep, of course.
All right. Okay. So let me know when you're ready to go. Let me get a glass of water. 1 sec.
Of course.
All right, is my position okay, guys? Center, you happy?
Yep, perfect. Just like before, please give us a countdown so we can have you on focus.
Okay, Stefan. Okay, yeah, we'll do it. We'll just play by ear. It'll be fun.
Shafi, you've got a nice coat on. You want to put a jacket on? Let me put a jacket on.
Yeah, put a jacket on. No one thinks you're an orthopedic surgeon, man.
Speaking of orthopedic, Shafi, I'm getting old.
Are you? What's happened to you?
So it's been like a month. I had a really, really bad back pain. I went to the orthopedic surgeon, actually. So it seems like it's my sciatic nerve, and it's a little bit of disc problem, kind of.
Look now, proper Italian-esque.
Yeah. Yeah, I can get a shirt as well, but at least it looks slightly more professional.
All right, we're ready to start in a few seconds. Okay, so
let me close the door. All right, let's start. I'm ready.
I'll count you down. 3,
5,
2, 1. So it's great to be here again with my wonderful colleague and friend, Professor Stefano Bini, who's joining us from California in San Francisco. He happens to be the professor of orthopedic surgery at the University of California. It's based in San Francisco. More importantly, he's an innovator, he's a disruptor, as well as being a super orthopedic surgeon dealing with joints and difficult joint replacements, from what I understand. Stefano, great to have you here, and thanks for joining us.
Shafi, such a pleasure and absolute honor to be here with you today.
So first, for the audience who may or may not know you, can you just tell them a bit about yourself and what you're doing at the moment and what drives you, Stefano?
Look, as you pointed out, I'm a practicing orthopedic surgeon. I do total joint replacement surgery. I do about 30% revision work at UCSF. And in that world, I'm interested in novel alignment techniques, something called kinematic alignment, and we just published an important textbook on the topic. It's a way to rethink the way we do knee replacement surgery. And as I was doing that, I got more and more interested in trying to define exactly how that improves things, and started working with companies like Google, for example, to use sensors and machine learning algorithms to really create digital twins of these knees so we can measure the results over time. And this is one small piece of my interest, because I also run a conference called the Digital Orthopedics Conference in San Francisco, really aimed at catalyzing the adoption of digital health tools, as you are doing here at Giant, in the world of medicine. And it's really been an exciting time.
Yeah, and actually you just ran the DocSF last weekend, wasn't it? So I remember coming to you inviting me to California a few years ago, and I was really amazed at how you're putting digital orthopedics at the forefront. And you're, I think, the only person who's really taken that on board to think about how does orthopedics develop its role using digital technology. It's so wonderful for that. It's a great thing that you've managed to achieve with the industry partners. Never easy to run a conference, of course, a new one that's going to disrupt the world of surgery. How was the conference this year? Tell us about it, Stefano. What did you have? All the exciting things.
You know, absolutely fascinating session. We decided to go back live because the connections that we make at DocSF, we simply couldn't do, even with thousands of people tracking us online. And we focused on, with your help, everybody's attention on 2037. We want to push things out 15 years to think about what the future might look like and disconnect from our perceptions of the present, because everybody has an idea of what will or will not work. Put into 2037, Nobody knows. We could think openly. And we had great discussions around the role potentially of blockchain and the impact you could have. Even ideas like NFTs that are tied to surgery that are then provided by DAOs. We were able to look at, with your help, discussing about virtual hospitals and what it looked like. How would you buy land in a virtual world to build a hospital on? We tackled all the variations and impact of things like not just the metaverse, but the future of AI and machine learning. What happens when not just the physicians have their personal assistant helping them make decisions, but also the patient helps them evaluate physicians and hospitals based on data that's publicly available. It just went on and on. It was one of those days that people would come up to you and go, "You changed my perspective of how I think about the future," and that was really our goal.
Wonderful. And it is one of the best conferences I've been to. So hopefully some of the audience members can join next year, either live in person or maybe even virtual if they can. So you have a great interest in innovation, Stefano. I'm very impressed with the fact that you've taken not just innovation, but used it into improving clinical practice.
Yes.
And so I know you're doing a really important project now, I think with Google, around wearables and sensors. Tell me about your work around this whole concept of wearables and sensors.
Oh, it's fascinating. Thank you for asking, Shafi. We went from let me take a step back. We've had the government in the United States has launched, and appropriately so, value-based outcome measure concept. The idea that we should be measuring things so that we understand the value we get from those investments in healthcare. The problem is that we went from physician-driven measures, which were not very accurate, to patient-driven measures, which are much better. It's wonderful to have a patient's perspective on outcomes. However, we're still missing something that's a little more objective. And objective measures help us not only track how folks do, which is really great, but also allows you to do things like adjust or go at risk with bundles on payments. It allows you to evaluate the impact of changes that you may make pharmacologically in a patient's wellness or on designs of implants. We simply need these objective design measures. So how do you do that? Because we don't really know how to do that at any level. We don't know how many metrics to measure. We don't know how long to measure them for, and we don't know how accurate they have to be. All this, of course, based on a quantified self-movement, the idea that we can actually start measuring how patients move through space. Individuals may not be patients, may be healthy folks. So the challenge before us is take one simple problem. We looked at knee surgery, and let's see if we can measure it using a sensor that can replicate an output that we currently have and we know works, which is the gait lab. But gait labs are very expensive, $150,000 give or take to build one. It takes hours to get data from a patient. You might get 2 or 3 seconds or a couple of minutes of data with hours worth of work. And it's just complicated. They're good research tools. But because we've been using them for a long time, it's basically a room-sized sensor. We can now take that information, if we could simply replicate it in a much easier format, take that information and use it to create, again, a digital twin, if you will, of a knee. So we're doing that with our Google partners. And what they've done with their ability to use machine learning using the raw sensor data from these sensors to really replicate the gait lab. Now, if we can do that and actually replicate the output and make those algorithms publicly accessible, as well as the data set used to train them, and put them in the wild, we're going to allow people who may live in an under-resourced environment, which could be in the United States or elsewhere, to take this information and use them to track their patients. Next step is to then take that data and create a modern outcome measure that's objective, that can be tracked longitudinally at any point in time, something we could never do before. And we don't know how useful that information will be in our world of musculoskeletal care. Once you have that, now you can start looking at question marks. Okay, well, can we act on that information and change the outcome? So it's a very exciting time.
It's amazing. And so I guess when you looked at your conference of 2037 or 15 years in the future, what does orthopedics look like in 2035? or 2037?
Oh yeah,
What do you
2035 was good, but 2037 was really awesome. We really hit it.
Yeah, exactly. So
No,
what are your thoughts then? What do you think you'll be doing in orthopedics specifically, and how it's going to change your life and your work?
Yes, we painted a picture in which we, of course, have a tremendous input of a delivery model that's actually based largely, as you pointed out in your video, big part of it is in the metaverse. In other words, in some kind of virtual environment, whether it's augmented or virtual, augmented reality, virtual reality, or a mixed version of that. Where we're seeing the delivery care model. But where we expanded from that, that's kind of where everybody gets that, it's obvious, is the training model. How do you get to the point where training orthopedic surgeons with companies like when you're getting on, you're moving on, Shafi, is to train surgeons in a virtual environment so that they actually are more capable. How do you take augmented reality to support not only them, but the supporting staff? We have a tremendous number of a shortage of staff in the operating rooms currently in the United States, to the point where you're shutting down ORs because we don't have enough staff. How do you create a larger workforce by using augmented reality, by supporting lower level technicians to do higher level jobs so that everybody gets upskilled? We talked about robotics and the impact robotics will have not just in surgical support, but actually surgical support as in like the technician that supports it, holds hooks, that keeps the blood out of the incision because they're using camera vision to support that. We looked at, as I told you, the whole financing side of it. Will we be looking at blockchain-based solutions to support that? We went on and on about how this looked. It was phenomenal.
Thank you for that, Stefano. So I think you've just talked about the future of orthopedics, but also of surgery as a whole, which I think is really exciting. You mentioned the issues around workforce planning, the shortages, which is a huge problem for us at the moment, because we've seen the lack of workforce, a lot of people leaving the profession, and also not being able to prepare for the millions of operations that we've cancelled due to COVID in terms of recovery program. So do you see digital technologies being used in that sense to allow us to get through the recovery for all those patients that have been cancelled or delayed because of COVID? What are your thoughts?
You know, in the short term, what we have available today, yes, absolutely, Shafi. Here's a few things. There's many patients who could probably put off surgery if they had sufficient physical therapy to get their rehabilitation in place, so they can actually strengthen the limbs, so that they can stabilize them and actually have a little less pain to get them to the point they actually can get to the operation. There's the upstream decreasing the burden by managing patients non-operatively piece, which you can certainly do with patient engagement platforms we currently have today. Employing augmented reality, particularly augmented reality, to support clinicians in their workflow and upskill them, absolutely. Virtual reality to teach new skills, that's probably the best application within that field. But also there's the whole post-operative, perioperative care piece, which people underestimate the challenge of, because it's a supply chain, and if you have a funnel that stops at the far end, it backs up. In other words, if there's no way for us to manage patients after they leave the hospital, or manage them well enough so they can leave the hospital early, like the same day of surgery or the next morning, because there's nowhere for them to go, or because they don't feel supported at home, now you have a challenge, because it simply backs up. And there's a lot of really cool technologies for the hospital at home, sensors at home, tracking at home, even drone deliveries to allow people to go home and feel safe, which are really going to support us. So I think that the entire supply chain of surgery, which is an interesting way to think about it, has opportunities for digital interventions to optimize them and to decrease the demand.
Yeah, no, I'm sure you're right. The last thing I was going to ask you about was the world of 3D printing. And I had the pleasure of having a conversation with Scott Parazinski, who was a doctor, but also an astronaut, when I was in Dubai a few months ago. And we talked about 3D printing and its use. It's been largely disappointing in terms of what the kind of the hope was around 3D printing. But orthopedics has always been an area where it's been ripe for 3D printing or creating casts or designing. Where are we in that world? Are we ever going to get to the stage where we can grow bone, for example, by using 3D printing? I thought that would have been a lovely bioengineering project for somebody.
Right. Here's the challenge 3D printing has faced. What is the problem they're trying to solve that currently doesn't have a solution that works and is not cheaper? And that's the challenge they had. It sounds really good in theory. If you're in an aircraft carrier and you don't want to have braces of 12 different sizes, you want to print a brace, that makes a ton of sense. But a $5 brace, it's hard to justify spending a couple hundred to make it with 3D printing by the time you add in all the costs. Where we're going to see an opportunity in orthopedics is not in the super sexy stuff of the implants, with the exception of custom implants for spine, where I think you're seeing an early adoption, is you're seeing an instrumentation. Currently, if you look at the burden and cost of sterilizing metal instruments and the number of trays necessary for this sort of thing to happen in orthopedics, we're very instrument driven. The ability to decrease that cost by doing 3D printing some aspects of it, either in the hospital or near a bunch of hospitals, if you have a particular printer, is going to be useful. The other interesting technology that we're starting to see is 3D printers that have biodegradable implants or biodegradable plastics, which also allows you for upcycling or recycling material. That's also starting to show promise because it decreases the overall cost of these devices.
Wonderful. So I think you're right. I think there is a degree of sensibility and realism now in some of the technologies. As you mentioned, you've got to find a problem that you're trying to solve rather than find technology that requires no problem in that sense. Then we've got a long way around. So look, I really want to thank you for this time you spent with us today, sharing your thoughts, your views, your research, the wonderful that you're doing in orthopedics. I'd encourage everybody to attend DocSF next year in face-to-face in California, if you can, in lovely San Francisco. What date is it next year, Stefano? Have you set the dates?
It'll be the fourth weekend in April, which I think will be the 29th and 30th, if I'm not mistaken.
There we are. And follow Stefano Bini on social media, but also DocSF. And he produces lovely podcast and also newsletters regularly. And he's not just about orthopedic surgeries, but surgery as a whole, and his research, which is obviously mind-blowing at the time. So, Stefano, thanks so much for joining us from California. And of course, we wish you well.
Thank you. Thank you so much.
It's an absolute pleasure to introduce our new guest here at the Future of Surgery session at the Giant European Health Tech Week. And it's Professor Marley Schwibben, who is Professor of Surgery in Amsterdam. And she's been a real pioneer for a long time in innovation. In fact, she was actually appointed as Professor of Surgery, but also serious games, which you can imagine a decade ago would have been unheard of. But she's very much a future thinker, thinks about innovation, actually also puts that innovation into hard research and clinical practice, which is the difficult part in some ways. There's some people who have aspirations. Marley lives and breathes innovation across clinical practice. So Marley, it's a real pleasure to have you here as always.
Yeah, it's a real pleasure to being here as always.
Thank you. Now you've just finished a 7-hour operation. So thank you for even finding time in that busy schedule to spend time with us. I'm really grateful.
No, but now I'm getting fired up again, of course. This brings me energy.
Yeah.
So thanks for inviting, Shafi.
Pleasure. So look, I remember hearing all about you many years ago with your Google Glass and your wearable glasses. And then I heard all about you from the black box in the OR collecting data. Can you share us your journey, your story of what you've been working on over the last decade or so and more maybe?
Yeah. Well, I think for people who don't know me, and that's probably most of the audience, I'm not a very typical surgeon in terms that I knew that I wanted to be a surgeon when I was 3 years old or so. First I studied design academy, then I studied health sciences, and I ended up studying medicine just because I liked studying so much. And I'm kind of good at it, and I didn't have another purpose in life at that point, so it kind of merged together. But it may sound a bit silly, but when you're very perceptive for influences at the age between 18 and let's say 28, that shapes you, and it makes you look at the world a little bit different from different perspectives, and that's something I cherished always. And for me, it's important in medicine to see where a piece of technology fits, and especially if it's able to solve something. I see many people who engage into innovation or technology because they think it's exciting or fun, and that's all fine, but it doesn't mean necessarily that the problem is fixed. And, coming from a really design engineer background, I tend to how do you say it, to think the other way around. Like, do we have a problem? And then I ask myself that 5 times, because sometimes we don't. So that's also important to realize. And the second question is, why cannot we solve it as we do as usual? And then, you know, many times technology doesn't fit, but sometimes it does. And I'm getting all stoked up if it's a piece of very simple technology or just smart thinking, or a piece of commercially available stuff that might work rather well in an environment it was not designed for. And that is where the gems and the pearls are for me, and what I like to do with my research group.
Brilliant. So tell us a bit about the projects you've been involved with recently. What's your current project? What kind of burns your fire, if you like?
Well, there are many. We started quite early on implementing a black box in the operating room. It's actually it's not my invention at all. It's an invention of a colleague we both know well, Theodor Grantcherov, and we used it first to see if our staff would accept it, because it's not nothing to have eyes and ears in the operating room, and it has to be privacy by design. People need to be blurred upon capture of video, not after processing afterwards. How to deal with patients.
Can you just describe what that black box is in the OR for our audience?
Yeah, sure. It's a system that collects all kinds of data, which are not heterogeneous, but which are recorded and synchronized at the same time, and stripped from personal identifiers. That means that voices are altered and pitched, faces are blurred upon capture, because we don't care whose face it is. We know who is in the OR, and you see yourself, so you know you're in there. But we need to do it in order to be able to pass all the strict privacy regulations, and it's a lot of technical stuff on which servers it should be, but mainly, how do you look back upon your joint performance? And of course, no one's going to look back at an operation of 7 hours for 7 hours. So you need to condense the information back to something that's really useful, and that's a journey in itself. How do you decide what's useful? What's useful for me, is that useful for you? What is standards? What is benchmarking for what type of operations? And you know, that is a story that has to be fitted in every environment, because in here it's different than in Canada, although we do the same operation. So that's a really big project, and we are rolling it out now on both our locations of the University Hospital. I live in Amsterdam, but we have 2 physical buildings. It's a merger hospital. It just recently merged. That means we have different cultures in 2 buildings. And that in itself makes it very exciting to use a black box, especially if people who haven't worked with each other before, who always think they are right, who now need to rely on someone else's routine, to see how that goes and how we can benefit and grow into a safe and also joyful environment to work in. Yeah.
And how has that had impacted on surgery as a whole? Have you seen any change in outcomes? Are you seeing a way of measuring performance? I mean, what's your metrics looking like?
I think what we did really well is to invite the ones who were most critical, because those are the people you really can grow from. People who applaud for you no matter what is nice, but it's not going to bring forward difficult initiatives as much as people who are critical. So we mobilized the internal criticism to take part and to help us shape it for the better, and that helped a lot in gaining trustworthiness, having people feel that they shouldn't be scared at all, because they had the deep insight what was happening and how it could not be misused, and you don't have to be afraid that you end up in YouTube. And all those things, and of course, the biggest question for us is: would you advise taking part in this type of conversations using black box material afterwards? And 99% of the people, only 2 did not, but the rest all said, yeah, we should do this. Not every day. But, like Max Verstappen, big fan of him, you only get better if you look back upon your joint performance. Yeah, of course, you need to be lucky sometimes as well. That is what Lewis missed out on. People don't know that we both, Chaffin and I, were at the final race last year.
That's right. Yeah, we were at the final at Abu Dhabi Grand Prix race together on different sides
On different
of the
sides.
spectrum, but
Yeah.
it was a great experience.
Yeah, great experience. But both teams, you can only get better by really looking at what is the common template of what is going on. And you may deviate in interpretation, but you need to have the objective facts.
Yeah. So moving away from that slightly, you've done some wonderful work, but also you've taken on a really important role in the Netherlands, and you're the Chief Medical Officer now, I think, is that right?
Chief Medical Information Officer.
Information Officer.
Yeah.
So tell me about the challenges that Netherlands faces, particularly after the pandemic and during the pandemic.
Yeah.
And what are you thinking about how you're going to almost reimagine what healthcare could look like? Because I think Netherlands has always been very innovative as a whole, as a nation, with the surgeons and doctors. And they've always pushed digital technologies quite firmly, that I've seen, certainly from my experience. So now in your new role, what do you see happening going forward, Marley? So what do you hope that's going to happen?
Yeah, well, what's important to realize is that our minister is now coming from clinical practice, but the former one during COVID was not. And in our ministry, there are a handful of people who come from healthcare. The rest is lawyers, is communication experts, is all kinds of people with great expertise, but not necessarily not on the health side. And what helps, and they do their best, but they just don't understand often the finesse of things, and they need to move forward as well. They have schedules and things need to be done. And so for me, it's really important that I help them understand why things work or not in the hospitals. And why in the Netherlands we don't have one electronic patient system. We have several, and things just don't communicate with each other. And they are, stressing a lot on general building blocks for the electronic patient file, so things can exchange. But the firms who own those systems, like Epic and Chipsoft, they ask hefty prices for every single alteration, and you cannot use the alteration that has been done for Rotterdam in Amsterdam. And it's a nightmare. And we just don't have. Even if you speak the same language, it's all. It has to be fine-tuned for every hospital, which makes it very pricey. Amsterdam University Hospital is not poor, but there are very small hospitals who have to do the same. That's an important one. And how do we communicate? Do we speak the same language? Do we need to speak the same language? That's also an important question. And how to, I always say, in the Netherlands, there's a lot of stuff going on privacy and the AVG law and stuff like that. But in the end, if you end up at the ER, you don't care about your privacy. You just want your doctor to see what's necessary to treat you well. But we don't have an opt-out regulation for that.
So you've got quite a challenging role ahead of you, I guess, like most healthcare systems around the world, around privacy, confidentiality, how you use the data, how you capture the data. But I guess your experience with the black box has given you real insights onto what data actually means, which I think is great. Someone like you who takes on that role in the Netherlands. I remember seeing recently, I think it was last year during the pandemic, you were supporting a small startup or something around some stoma things for children, right?
Yeah, that's correct.
Tell me about that story, because I love that story, by the way.
Yeah, that's well. Okay, how I'm going to condense this. We knew that there were quite a few children who had to have a stoma, but there was only material for adults on stomas. And the big problem of those children is does not appear in the classroom or in the playground who also has a stoma. So those children are, they are vulnerable in many ways. And we decided to build a Stoma app. It's called Stomakker. Makker is a Dutch word for friend, so Stoma friend, in which they have, it's for different age categories. They participate in it as well. And for the very young one, it's like we call it the stoma rose. How much water does your stoma rose need to be? It's like a Tamagotchi, basically, a little bit like that. Because if they end up in the hospital, it's usually with dehydration. So there are different mini games inside that Stoma app, but there's also, and it's very important, a protected channel, which they can only access if the doctor gives the code and the parents consent. So because you don't want someone with a strange appetite for children to be inside the Stoma app, to really have peer contact, so they can find their friends who have a stoma as well, via the app. And in that way, they have their peer support. And you also hope, of course, they have their friends and everyone around them, but that's not the same as another child who also has a stoma.
What a lovely project for a population that was underserved. And you said their children are vulnerable, having a stoma isn't particularly pleasant. Having that kind of support is great. And I think that obviously comes from your background of serious games and your design thinking, etc. So if someone wants to come into this profession now and sees Professor Schwibben and say, I'd love to be like you, which I'm sure many people would aspire to.
Beware what you wish for.
We're living in a world that people want to portfolio careers, want to innovate, want to make an impact. How should they go about doing it, Marley?
I think I get how do you say it? I'm getting itchy if I see something that has not been solved, of which I think I can solve it. We did waste bin vaccine for vaccines that went to waste. We saved thousands of vaccines who otherwise would have gone to the dustbin. It's a lot of it's about, if you think, why has this not been solved? If you genuinely wonder about something, then do something with it. I have a motto. I have a website, of course. It's marleyschrijven.nl or .en. And my motto is, it's French, il faut le faire. You just have to do it. Why not? What can happen? You can feel, what I feel many times. It's not bad. But, just do it. If you're getting itchy, you can complain, you can ignore, or you can do something about it. I get happiest of the last part.
Wonderful. So you solve problems, you get itchy if there's something that hasn't been solved. And that makes sense. I think, we're inquisitive by nature as human beings, but sometimes we stop at being inquisitive. We don't go
another
further.
word of being inquisitive is of course homo ludens, the playing person. We all play, but one person translates that into gaming, the next one in solving Sudokus, the third one in playing with the grandchild, the fourth one in playing bridge, the fifth one goes fishing. We all play.
Yes.
That's
now, of course, it's Wordle for most of us on Twitter. That's
I'm still on Pokemon.
Pokemon. Well, listen, it's been a delight to have you today, and thanks for sharing your journey, the work that you've been doing, which is seriously amazing, hopefully inspiring the next generation of young surgeons who want to innovate and disrupt and solve some of the problems that we're facing. So thank you for joining, especially after such a marathon operation. Thank you.
It's a pleasure always. I'm already refreshed.